Hello and good afternoon. My name is Marcia Mott, and I'm the coordinator for the University of Florida Health Wellness University. We have a great presentation today on a topic that affected more than 795,000 Americans last year, stroke. We have two great presenters. After their presentations, we're going to take your questions, and you can submit your question at any time during the presentation using the Q&A button at the bottom right of your screen. I will anonymously read your question aloud at the end of the presentation. Our first speaker is Dr. Anna Khanna. She is a neurologist and the medical director of the UF Health Comprehensive Stroke Center. Her interests include acute stroke management and continuing research in several clinical trials treating acute stroke. Our second speaker is going to be Dr. Nohra Chalouhi. He is a neurosurgeon at UF Health, and his clinical interests include endovascular stroke surgery and spine surgery. We're very fortunate to have these two amazing physicians providing excellent care for stroke in our community. Dr. Khanna, I'm going to turn it over to you now. Thank you.
Hello, everyone. Good afternoon, and thank you for inviting me to speak about the topic I'm most passionate about, which is stroke. Marcia, can you see my screen? Yes.
Yes, we can see your screen.
Perfect. So today is, as most of you know, it's World Stroke Day. It's October 29. And I'm speaking to you from the University of Florida Stroke Center. And we're going to start with a video of one of our patients that presented to our hospital.
Eric and I have been together 14 years. We have two children.
The day that the stroke happened, I was going to take a shower, so I went to the laundry room.
When the kids saw him go in and out of the laundry room a couple of times. But then our son didn't see him come back out for a couple of minutes. And so he went in to see what Daddy was doing, and he saw him there laying on the floor. I kind of got there next to him, and his speech was slurred. I did ask him if he could smile for me, and he did. It was very lopsided. I had my son run and grab my phone to call 911. I said, my husband is having a stroke.
When Eric came to the emergency department, he was a stroke alert. So the entire stroke team was ready and knew that he was coming.
On his initial examination, he couldn't move his left side at all. He couldn't communicate, and he could not follow any commands. When he went into the CAT scan, we made the decision to deliver treatment immediately because he was having an acute ischemic stroke.
Time is brain and every minute matters. And so we have gotten this down to a very efficient process, and we were able to get Eric up to the surgical OR very quickly to start that mechanical thrombectomy procedure.
Immediately after the procedure, he was taken to the ICU. He went from inability to move the left side to completely lifting the arm and leg with almost full motor strength. It was pretty amazing. And as the couple of days went by, his speech began to recover as well. He began to follow some commands, and within 6 days, he was actually discharged home instead of having to go to a rehabilitation center.
From the time that after the stroke to now, I've progressed quite a bit. I went from not being able to name my kids to being able to talk to them now. And I mean, I mess up sometimes, but it's not like it used to be.
Having the care that he had is going to assure that our family is able to keep going. It literally meant life or death for our family. My husband is going to come back from this debilitating stroke and he's going to be able to help be a provider and to raise our children. And the only reason that he's going to be able to do that is because of everything that they were able to provide at UF Health. So I am beyond thankful.
I'm just trying to take this video off. Okay. So since it's World Stroke Day, we're going to talk about some of the world statistics. So someone on the planet has a stroke every 2 seconds. And before everyone leaves today, you will plan to practice prevention instead of having a stroke. And you will know the signs of stroke in order to get treatment as quick as possible, as in this case, Eric did. And that is why we were able to treat him and reverse his symptoms so he can go back to his normal lifestyle. 1 in 4 people worldwide will have a stroke. 1 in 4, but up to 80% of these strokes may be prevented. High blood pressure is the #1 controllable risk factor for stroke. In fact, nearly half of Americans have high blood pressure, or what we call hypertension. These are some facts about blood pressure. Normal blood pressure is less than 120/80. 80% of patients and strokes that occur can be prevented. If you're 50 years old, your life expectancy can be 5 years longer if you do not have hypertension or your hypertension is well controlled. 1 in 3 American adults have hypertension but don't even know they have it. So blood pressure has to be checked frequently with your primary care physician because these strokes from hypertension can be prevented. As mentioned earlier, each year in the United States, 795,000 people will have a stroke. A stroke in the United States occurs every 45 seconds, and every 3 minutes, a stroke-related death occurs. Women between the ages of 45 and 54 are actually twice as likely to die from a stroke than they are from breast cancer. Stroke now remains the 5th leading cause of death in the United States. However, it still remains the leading cause of disability. And as you can see, and as I mentioned previously, stroke does not discriminate. It does not choose whether a person is younger or older. It doesn't choose a specific ethnic background. All of these famous people in this picture have had a stroke. Some of these you may recognize. This is Luke Perry from 90210. He actually passed away from his stroke about a year ago. However, most strokes do occur in people that are older. And if you look at these bars from every decade of life, your risk of stroke will actually double. So yes, younger people are susceptible to stroke, but as you get older, in the ages of 75 to 85, your risk of stroke will definitely be much higher. When we talk about stroke, we're going to divide stroke into 2 categories. The first category is ischemic stroke, and that stroke occurs from when there's blockage of a blood vessel. So that could occur when a little clot travels from someplace else in the body, most frequently the heart, and block a blood vessel inside the brain. And that is when you get an area of the brain that doesn't get enough oxygen, and that's when you have a stroke. Or you can have a blockage in a larger artery, like for example, in your neck, like a carotid artery, you get a big cholesterol plaque, and that causes blockage, and that will result in an ischemic stroke. The second type of stroke we call hemorrhagic stroke, and that's when there's bleeding in the brain. This stroke occurs when there's a rupture or a burst in a blood vessel causing bleeding inside of the brain. Most of the strokes that we do see, about 83 to 85% of them are going to be ischemic strokes when there's a blockage in a blood vessel. The rest, about 15 to 17%, are going to be these hemorrhagic strokes when there's a burst in a blood vessel. So definitely by far the majority of the strokes are going to be these ischemic strokes. We're going to divide the ischemic strokes into these 4 subcategories. One is being large artery atherosclerotic, and there when there's a clot that forms in an artery outside of your brain, like in your neck. This happens to be a big artery, we call it carotid artery, and there's a blockage here causing what we call a stenosis or a narrowing in the artery, and this is why the stroke occurs. Another stroke we call lacunar or small vessel, and these are these tiny, tiny microscopic arteries that we actually cannot see on a CAT scan or a CAT scan angiogram, and these kind of strokes occur very deep in the brain, secondary to high blood pressure and diabetes. Another common stroke is what we call embolic stroke, and that's when a clot travels most often from the heart, but it actually can come from other areas as well, and it blocks an artery inside the brain and causes a stroke, and this is what we call embolic. And a large category here, about 30% of the strokes are what we call cryptogenic, so like tales from the crypt, is these are the strokes that we do a big, big workup. We look at all the arteries, we look at the heart, and we actually don't really find out exactly why someone had it. So that occurs more rarely and more commonly in the younger population when we do everything that we possibly can, and we still can't get to the reason why somebody had a stroke. The second stroke, the less common stroke, is the hemorrhagic stroke when you have bleeding in the brain. We're going to divide that into 2 categories. We're going to call intracerebral hemorrhage, meaning bleeding inside the brain. This is blood inside the brain. And this is something called a subarachnoid hemorrhage. And this is blood in the spaces, all this white stuff in the spaces of the brain, which you most commonly get from a rupture of a cerebral aneurysm. As already mentioned by Eric and other people that you've talked to about stroke, time is brain. When it comes to stroke, time lost is brain loss. So the faster you get treated, the better your outcome and the better your chances of returning to independence. So the question is stroke treatable? And as if you've seen in the video, yes, stroke is treatable, but you must come to the emergency room and to the hospital as quick as possible because brain cells do not come back. Brain cells, once they die, they cannot regenerate and they cannot be restored. So if we see you too late, no matter what treatments we offer, we will not be able to reverse those brain cells and your neurological deficit that has already occurred. So you must know the symptoms and signs of a stroke, and whenever you see those, you must immediately call 911. So what are the symptoms of a stroke? We want you to learn fast. F stands for facial drooping or weakness of one side of the face. A stands for arm weakness. So you ask somebody to hold up their arms and one arm either falls down or they're unable to lift one arm. S is for speech. You ask someone to say your name or repeat a simple sentence like, I am here. And if they cannot repeat it, you must do this, T, which is time, you must call 911. So if you have all of these 3 things, an F, an A, and an S, the likelihood that you're having a stroke is over 80%. Very easy to remember. So remember fast in any of these cartoon images that you may see. So spot a stroke, look at fast, and call 911 immediately. What are the other symptoms of a stroke? Well, you can have sudden, and remember, strokes are very sudden. It's not something that develops over weeks and months. So a sudden onset of numbness or weakness of one side of the body affecting the face, arm, or leg. Sudden trouble speaking or understanding, and that is part of the fast mnemonic. Sudden trouble seeing in one or both eyes or double vision. Sudden trouble walking, dizziness, or loss of balance. All of a sudden, you're starting to walk like you're drunk. Sudden severe headache, the worst headache of your life that is very uncommon for someone. And this is very suggestive that the stroke may be a bleeding type or a hemorrhagic stroke. These are the stroke risk factors that we unfortunately cannot change. One is age, as I described to you. For each decade of life, your risk of stroke doubles. Sex, more women die from a stroke and have a stroke than men. Race, so certain ethnic groups such as African American and Asian population and Hispanic population have strokes earlier in life and more severe strokes. History of a prior stroke. So if you already had a stroke, your risk of a second stroke is increased. And family history. So we cannot change genetics. So if you have some sort of a family history of a clotting problem or aneurysms that burst, then your risk of stroke may be increased. But there are many risk factors that we can change. And with these risk factors being modified and controlled, we can prevent stroke. So hypertension, high blood pressure, as I mentioned already. Heart disease, especially a condition called atrial fibrillation, which is an irregular heart rate. In fact, if you're between ages of 80 and 89, if you present with a stroke, it's a 23% chance that you probably do have underlying atrial fibrillation. Cigarette smoking and having what is called a TIA or a mini stroke. So if you present at any point in time with a mini stroke, you have to treat it the same as you would with somebody that has a full stroke, because your risk of having a stroke after a mini stroke is very high. So you shouldn't just forget and not be treated just because your symptoms reversed completely. Diabetes is a very preventable and treatable risk factor. Elevated cholesterol, or what we call lipids, weight reduction, being at a healthy weight, and sedentary lifestyle. So it is recommended that you have some sort of an exercise routine. It doesn't have to be very intensive exercise, but at least even walking 30 minutes at least 5 days a week would be very, very beneficial to reduce not only stroke, but all overall cardiovascular disease. So these are the cardiac or in the heart risk factors that can cause those embolic strokes, when you have that little clot that travels from the heart and lands in an artery inside the brain and causes a stroke. The most common by far is going to be this atrial fibrillation, which this irregular heart rhythm, which is actually a pretty benign rhythm, but what it does is it causes clots. And you can have valve problems, and you can have somebody that has a heart aneurysm or a heart attack. And I'll show you some pictures of what that looks like in a minute. So atrial fibrillation, how do you know that you have atrial fibrillation? When some people may experience a racing heart rate, some kind of a fluttering or a palpitation. Some people may actually have some shortness of breath or lightheadedness. However, most people can have nothing at all, no symptoms at all, and it's incidentally found on an EKG when somebody presents with either a stroke or a mini stroke, a TIA type symptom. So that whenever you present with any of these things, always doctors will do an EKG to make sure that you don't have underlying what we call paroxysmal or intermittent atrial fibrillation. And these are the other reasons you can have a stroke. So this is somebody that has a stenosis or a very, very tight mitral valve, and you can get clots forming on that valve, and that can kind of shoot up into the brain. You can have somebody with a mechanical valve. So this is a metal valve, and you can get clots forming on top of this metal valve. And that's why people that have a valve replacement with a metal valve, not a tissue valve, a metal valve, always stay on blood thinners like warfarin. Most of the time it would be a warfarin type of medication, or Coumadin, as some of you may know it. This is somebody that's had a heart attack, and part of this heart muscle doesn't actually move or contract appropriately. And whenever blood stagnates, whenever it's not moving continuously, it can actually form a clot. And then when that muscle contracts, part of this clot can go up into the brain. And this is a more rare type of stroke, but yet something that you should be aware of. This is bacterial stroke. So these are actually bacterial or infection type of clots, actually like infectious particles that form on the valve, and they can actually travel to the brain and cause an infectious type of stroke. When do we see that? We see that when people that have a valve problem or a tissue valve or some sort of a heart valve surgery, and they often tell you when you go to the dentist, you have to take antibiotics, and that's to prevent an infection from the tooth traveling onto your valve, attaching, and then potentially causing a stroke and going into the brain. But from all of these heart things, all these cardiac risk factors, the most common by far is going to be this irregular heart rhythm or atrial fibrillation. So what are the treatments for stroke? Well, in 1996, they approved the medication that we all know as TPA, or a clot buster. This medication is given within 4.5 hours from the time of symptom onset or from the time that you notice that you had stroke symptoms. We don't usually use this outside of this 4.5-hour window because at that point, the harm of this blood thinner, it's a very strong blood thinner, it's a clot buster, can actually overweigh its benefit. And the biggest and scariest side effect of this TPA is bleeding in the brain because it's a very strong blood thinner. However, if you select people within that 4.5 hours, they're selected by a medical professional, the risk of bleeding from this medication is very, very low. It's actually less than 6%. However, usually in our institution, we actually have a rate of less than 1%. So the benefit of this medication significantly outweighs the risk of bleeding in the brain. So what happens when you come to the emergency department? Well, we have to do a lot of things before we can administer the TPA. So you'll kind of arrive by the ambulance, which is the preferred method of getting into the emergency department. You have to be evaluated. You have to have a CAT scan. Why do you need a CAT scan? Is because we have to do a CAT scan to rule out that you are having an ischemic type of stroke, a blockage stroke, or bleeding in the brain. And you could imagine if you have bleeding in the brain and we give you a clot buster like TPA, we could have a very devastating outcome and you could potentially die. So that's why everybody has to have a CAT scan before they get TPA. So you have to have a CAT scan. We have to look at the CAT scan. We have to mix the TPA. We have to put a special IV line, and then we have to deliver the drug. So a lot of things have to happen on our end for you to receive the medication. And that's why it used to be a standard of 60 minutes from the time you arrive to the time you receive the medication. But our standards have changed, and we do these things much more quickly because the new standard by the American Stroke Association is now for you to receive the medication in less than 30 minutes. And sometimes we're even doing it faster. We've had several patients that received the medication within 15 to 17 minutes. So the reason that we are worried about giving TPA outside the 4.5-hour window is because of bleeding. So outside of the 4.5-hour window from when your symptoms started, the risk of bleeding significantly increases. So if you look here, the blue bar means benefit, the green bar means harm. So if you present within 90 minutes, you get a significant benefit from TPA. If you present within 180 minutes, you get a significant benefit of TPA. Even when you present up to 270 minutes, you still are getting the benefit, but you could see how the benefit begins to decline the later you present to the hospital. And you could also see how the harm begins to go up the later you present to the hospital. So if you present within that 5 to 6 hour time window, you could see that the harm of TPA, the green bar, is actually higher than the benefit of the drug. And that's why we always give the drug within that first 4.5 hours. There are limitations of TPA. So if you have a very large clot, it's very difficult for the TPA to open it. Sometimes people have contraindications to TPA. So if an example, they're already taking a blood thinner. such as Coumadin or warfarin, or some of the newer blood thinners like Xarelto or Eliquis, then you cannot get IV TPA. Also, people that had a prior bleeding type of stroke or bleeding in the brain, giving TPA may be a little bit dangerous. So we have to do something else. And this is what Dr. Chalouhi will be talking to everyone about. It's additional ways to remove the clot out of your brain. And we have different procedures. Most of the time, the doctor will go through your artery inside your groin, and they will feed a wire all the way up to the brain with a special type of a stent or an umbrella type of a device that will then pull the clot out of your brain. And you will be hearing a lot more about it from Dr. Chalouhi, so I will not steal his thunder. When you are admitted to the hospital, you will get certain tests. So the one test that you will get is called a carotid Doppler. And that is a test looking at the ultrasound of your carotid arteries, the arteries in your neck. Because as I showed you before, you can get a cholesterol plaque in the neck that could either block off the artery completely, or it could break up and go to other areas within the brain and cause a stroke. So we have to make sure that your carotid arteries are doing okay. You're going to have an echocardiogram, which is an ultrasound of your heart. And what we want to see is if you have any clots in the heart, all of those things that I showed you earlier. So clots in the heart, we want to see if you have atrial fibrillation. We want to see if you have a problem on one of the valves, or any kind of risk factors that can come, any clots that can come from the heart. You'll often get an MRI and possibly an MRA, or sometimes a CTA, and that is anything that's an A is called an angiogram. And then we want to look at your arteries both inside the brain and outside the brain. And the MRI is very beneficial because it can find little tiny strokes. And not only could it find new strokes, but it can also tell us what your brain's been doing over time if you had other or older strokes that we have to worry about or modify treatment accordingly. You will also get some blood tests. The most important test is called hemoglobin A1C, and that's to look for diabetes. You will get a lipid test, a lipid profile to look for your cholesterol to see if we could modify those risk factors better. Now, some younger people that we cannot find any of obvious risks for strokes, then sometimes we do more extensive testing and we look for clotting and different genetic tests to see if they have a predisposition to having a stroke from other more atypical type of factors. If we do find that you have a blockage inside the artery in the neck, we can do a procedure called a carotid endotorectomy. So this is a cartoon vision of somebody in their neck. This is the carotid artery. They have a very ugly kind of a cholesterol plaque. That artery can be opened, the plaque is taken out, and then that artery is sutured back up. And this procedure is usually done under general anesthesia, and this is called a carotid endotorectomy. Another way to fix that area of blockage, this is a cholesterol blockage that's blocking the flow in the carotid artery, is to put something called a stent. So this is different than those stents that we use to remove clots from the brain, because those don't stay there. These are the same stents, similar stents to what they put in the heart. So the stent is put in, it kind of opens up this artery here, and it kind of smushes the cholesterol plaque against the wall. So now instead of having this blocked artery here, the artery is going to be wide open. And this procedure does not often need full general anesthesia, where you have to have full ventilator, like a breathing machine and all of that. And this is an example of a stent that is placed in the carotid artery. So the carotid artery can be fixed with a carotid endotorectomy, or it can be fixed with a carotid artery stent. And always, after you come in with an ischemic stroke, you will be put on a preventative medication or a blood thinner. Mild blood thinners include aspirin, a medication called Agrinox, which we don't use as often anymore, which is a combination of two medicines. One is aspirin, and the other one is called dipyridamole, which makes up the Agrinox. And all you really need to know it as Agrinox. And the third one is Plavix, also known as a generic name, clopidogrel. So you often will be put on at least one of them. And sometimes if we find a particular type of blockage, we may send you home on a combination of aspirin, plus the Plavix, at least for a temporary duration of time. If we do find a clot somewhere, like in your heart, or we find that you have atrial fibrillation, you will be put on a much stronger blood thinner. So the older drug is warfarin or Coumadin, or you'll be put on one of the newer drugs, and there's 4 of them now. One is called Pradaxa or the Bigatrin. The other one is Xarelto or rivaroxaban. Third one is Eliquis or Apixaban. And the 4th one we don't use very commonly, but I just want to mention it because it is out there. It's called Savesa or Endoxaban. Most frequently, we probably use either Apixaban, or Eliquis, as you know it, or Xarelto. And I'm sure that some people in the audience either have heard of this or are taking that medication currently. And most of all, not only the medication, we're going to encourage you to change your risk factor profile. So prevention, and risk modification is most important. So antihypertensives or blood pressure medicine to keep your blood pressure less than 120/80, which is your long-term goal. Statin therapy, which are cholesterol medications, and our LDL, which is our bad cholesterol, we want that number less than 70. So very, very aggressive cholesterol control with high dose, usually higher dose, what we call statin medications or cholesterol medication. Optimal control of diabetes, want to make sure that your sugars are well controlled. We're going to recommend a healthy diet, usually a Mediterranean diet, physical activity, as I mentioned, 30 minutes a day, at least 5 times a week. Smoking cessation, alcohol in moderation, and definitely stroke symptom education. So you know when you're having a stroke or your friend or a colleague or a neighbor is having a stroke, so you could recognize those fast symptoms and call 911 immediately. I'm going to switch gears a little bit to that less common stroke, which is called your hemorrhagic stroke. And remember, we divided that stroke into 2 categories. This is intracranial hemorrhage. So this is all of this white stuff inside the brain, bleeding inside the brain. So this is somebody that comes in with bleeding inside the brain, this white stuff. And this is that same person with expansion. So these type of bleeding, sometimes they just expand on their own and there's not a lot we can do about it. So this is the same person several hours later, so came in with this much bleeding, and now all of a sudden this amount of bleeding expanded on its own. And that's why it's very important when people come in with these bleeding type of strokes to control the blood pressure immediately, very, very aggressively to prevent this expansion. And you can imagine this person had some mild weakness on the right side and later developed this and actually died from this what we call hemorrhage. By far, the most common reason for intracerebral hemorrhage, in fact, 70 to 80% of cases of having bleeding in the brain is secondary to hypertension. So high blood pressure not only causes ischemic type of strokes, but also it causes hemorrhagic strokes. These are the less common reasons. You can have something called amyloid angiopathy, which is a protein that deposits in those blood vessels and cause them to be very fragile and weak, and you can get bleeding inside the brain. Sometimes you can be on warfarin or other blood thinners, and you can get bleeding in the brain, especially if you fall and have significant head injury. Aneurysms, trauma, meaning head trauma, like a car accident, or you fall, especially if you're on blood thinners, that can lead to bleeding in the brain. Neoplasm or cancers, there are certain cancers that travel to the brain, or cancers that originate from the brain that can have bleeding in them as well. Venous sinus thrombosis is when you have clot in a vein in the brain, and that can sometimes have bleeding. And this we see actually not uncommonly, hemorrhagic conversion of an ischemic stroke. So meaning somebody comes in with a blockage type of stroke, but a stroke is very, very large, and then you develop some bleeding in it. Vasculitis is when you have inflammation in arteries, and that can cause, and these are very, very atypical hemorrhagic type of strokes. But it's inflammation in a blood vessel, and that can cause you to have bleeding in it. And drugs, so things like cocaine, amphetamines, any kind of what we call sympathomimetics, or the kind of amphetamine type of medications, not medications, but street drugs, can cause bleeding in the brain. And the other one that we talked about is subarachnoid hemorrhage. And by far the most common reason for subarachnoid hemorrhage, if it wasn't brain or head injury, is going to be from a rupture or a burst of an aneurysm. So you have this little aneurysm that's sitting here, and it just kind of bursts and bleeds into the brain. And those actually we can fix. We can either we open up the brain and we put a little clip on the neck of the aneurysm and it kind of goes away. Or sometimes we could do something that is called a coil, where we put these little coils inside of an aneurysm and just make it go away or fully obliterate it. So from this topic, I want you all to walk away knowing that stroke is a medical emergency. You should know the symptoms of a stroke. You should know you're fast and immediately call 911. You should know your risk factors and know that 80% of strokes are preventable. You should monitor your blood pressure, cholesterol, and your sugars, smoking cessation, or actually don't smoke at all, alcohol in moderation, and daily exercise. And if you need any further information, there's all of these websites that are available, strokeassociation.org. If you go there, it will lead you in all kinds of directions, help you find stroke support groups, help you find doctors, help you find anything really, and anything, educational materials, anything that you want to learn about stroke. And that is my last slide. Thank you all for your attention. I'm trying to unshare my screen.
That's okay. Yeah, I was gonna say, as soon as we get you to stop your screen share, we'll get Dr. Chalouhi to turn on his, and we'll be ready to go for the next half. And some of you have already submitted questions, so thank you, and we'll get those answered in just a minute. Okay, Dr. Chalouhi, thank you.
Hello, everyone. My name is Nohra Chalouhi. I'm a neurosurgeon at the University of Florida. I specialize in the treatment of neurovascular disorders, including acute ischemic stroke. My presentation will focus on acute ischemic stroke because, as Dr. Khanna has, very eloquently explained, it is the most common the most common type of stroke and the one that we can act upon and make a difference. Okay, I have no disclosures. So again, briefly, we have two types of strokes. On the left side, you see the hemorrhagic stroke type, which is the less common type, and it's due to a blood vessel rupturing in the brain and causing a hemorrhage inside the brain. The treatment of this type of stroke is completely different from the other type of stroke, which is ischemic stroke and commonly referred to as just stroke. And an ischemic stroke, again, is caused by a blood clot that stops the flow of blood into the brain tissue. So this is a CAT scan. Just a CAT scan can very quickly differentiate between the two types of stroke. On the left side of the screen, you can see a hemorrhagic stroke because blood on a CAT scan appears white, as opposed to an ischemic stroke, which on the right side of the screen, you could see it's a darkened area of the brain. In general, we like to get patients before they develop this darkened area in the brain, which in general means that the damage is irreversible at that point. So if there's one message to remember from this presentation and Dr. Khanna's presentation, it's that time is brain. We have 22 billion neurons in the human brain, And every minute during a stroke, we lose about 2 million neurons. So in 10 minutes, that's 20 million neurons. So every minute matters. Stroke is a medical emergency. That is the key message here. Okay, so I'm gonna focus primarily on the endovascular treatment of stroke. What is the endovascular treatment of stroke? It's also known as mechanical thrombectomy. And what that implies is basically a surgeon removing a blood clot from the brain, from the blood vessel in the brain, and restoring the blood flow to the brain. That is the principle of endovascular management of stroke. So on this screen, I have highlighted the major vessels in the brain, the large vessels. You're gonna hear that terms, frequently, large vessel occlusion. What is a large vessel occlusion? It's when a clot blocks one of the large vessels in the brain. And the large vessel in general are the internal carotid artery. There's two of them, one on the right, one on the left. The middle cerebral arteries, again, there's two of those, one on each side. And third, the basilar artery. So these are the three major arteries that in general are the sites of large vessel occlusions. Now, 2015 was a big year for stroke because in 2015, several trials, clinical trials were published, and they all had the same conclusion, that endovascular therapy improves the outcome of patients suffering a stroke from a large vessel occlusion. Specifically, I'm gonna just mention one of these trials, the Extend-IA trial, which was published in the New England Journal of Medicine in 2015. This journal is the #1 journal in medicine. So obviously it was a very well-designed study. What the investigators studied is whether endovascular therapy improves the outcome of patients with large vessel occlusion over TPA alone. And what they found is that endovascular therapy actually improves the outcome by almost a twofold factor. Specifically, patients who underwent endovascular therapy had a 70% chance of a positive outcome versus those who did not and only had a 40% chance of a positive outcome. Furthermore, the trial had to be stopped after the enrollment of just 70 patients because of due to the efficacy of endovascular therapy. We didn't want to deprive patients from highly beneficial treatment. So this slideshow just highlights one quick point, that endovascular therapy is more beneficial than TPA alone for patients who are having a stroke from a large vessel occlusion. So technically you can forego TPA as long as you're able to get the patient to the OR to have endovascular therapy performed. So that is a key point that was shown just recently in the past couple of months in a large study that was performed in China, and it was published again in the New England Journal of Medicine. So now, how do we perform mechanical thrombectomy or endovascular therapy? As you can see on the left side of the screen, it requires a biplane fluoroscopy machine. That's basically a machine that delivers X-ray, and this is the surgical bed. The way we access the inside of the vessel is either through the groin. As you can see here, we generally like to have both groins exposed as well as the wrist. In the past 2 years, there have been a complete shift from going through the groin to going through the wrist. So as you can see, that's the patient's wrist. This is how we access the inside of the vessel, and that's what we call a sheath. A sheath is basically the catheter that allows us to access the inside of the blood vessel. So there's several techniques to retrieve clots from the arteries in the brain. The most common and the one that works the most is direct aspiration. And what that involves is bringing a large diameter catheter, as you can see on the screen, to the actual clot in the brain to engage that clot, aspirate that clot, and achieve reperfusion. The recanalization rates are about 70 to 80% with this technique alone. But that's not the only technique, but that's the one we use the most, and that usually very successful. So here's an example. That's a stroke patient that I was getting access on. So you can see I'm going through the wrist, and that's my needle. As soon as we get blood flow, we get the wire in, and as we get the wire in, then we introduce our sheath there, and this allows us to get access to the inside of the vessel. So this is how we get access to the brain. There's no cuts involved. It's just a needle stick, and we dilate, and this is how we get access to the inside of the blood vessel and subsequently to the brain. So this is the what we call a radial run, which means this is the artery in the forearm and then the arm. And here what you can see is my my wires right there navigating the arteries of the forearm and the arm. Next, so this is the wire that we just saw, and what we're gonna do, we're gonna bring the wires all the way up to the chest, then bring our catheters. And now you can see my selection catheter is pointing to the left side. So it's in the left common carotid. So this is basically how it's performed. You get access in the wrist, you navigate your catheters all the way up to the chest, and you get access to the carotid artery. Okay, and this is, again, that's the patient was having a stroke on the left side of the brain. So now you can see my catheter. It's kind of hard to see a little bit, but if you focus, you'll be able to see it. So that's my catheter going all the way up in the carotid on the left side. So that is the internal carotid artery. I can play it again so we can watch it one more time. Here you can see the catheter going all the way up to the brain. And this is the key image here. So this is the internal carotid artery. This is the anterior cerebral artery. And then the middle cerebral artery, you see a stump of it, just that. That means that there's a clot that is sitting right there and occluding, blocking the blood flow to the brain. And the goal here is, like I mentioned, to bring a large diameter catheter through the wrist or the groin and engage the clot all the way and then aspirate that clot. And what that video is going to show you is how this is performed. So now you can see my catheter here engaging the clot, and here it's in the clot. And then we turn the aspiration on, aspirate the clot back, and here you go. You got the full recanalization. We're able to restore the blood flow entirely to the left side of the brain. I'm going to play it again one more time. This is the catheter, large diameter aspiration catheter, engaging the clot. Aspiration is on. And then now you'll see how you'll restore blood flow to the left side of the brain. This is another type of stroke. This is a basilar artery stroke. Remember I showed you the basilar artery. So the basilar artery, there's only one basilar artery in the brain, and it supplies the brain stem. You cannot survive, you cannot live without your brain stem. And as a result, you cannot live without your basilar artery. So if there's an occlusion in the basilar artery, this is, it will lead to death in 100% of the cases, unless an intervention is performed. In general, patients presenting with this type of occlusion in the basilar artery are comatose. And we try to operate on them emergently to retrieve the clot. So this was a patient in his 70s who presented comatose almost 12 hours after the onset of symptoms. And I'm going to show you here. So you see the site of the occlusion, how the basilar artery is occluded right there. And this is my wire. And you can see my catheter going up, going past the clot, engaging the clot, aspirating it, and restoring the blood flow. And this is the type of clot that we get back. So I can play it again real quick. So you can see my catheter going up one more time. You can see the catheter going up here and engaging the clot and turning the aspiration on. Very good. So now if aspiration doesn't work, our second option is to place a stent retriever. And it's a stent that doesn't stay there. In general, we retrieve those stents and this allows us to retrieve the clot. So the way they work is, as you can see in this video. So this is, again, the perfusion catheter. And then we're going to bring our wires all the way up to the clot, which you see in the middle cerebral artery on the left side. Then we bring a catheter past the clot. Then we will bring our stent retriever all the way up to the clot. And then deploy the stent retriever, as you can see it here. And we leave it there for 5 minutes to engage the clot, because we want to be able to pull both at the same time. We don't want to just pull the stent and leave the clot behind. So we leave it there for 5 minutes, then we pull both at the same time. And this allows restoration of blood flow to the brain. So no patient is too young. This is the example, one of my patients. This was a teenager presented to the emergency room at the University of Florida. Luckily, within 3 hours of onset, his mom brought him. He had paralysis on the left side of the body. We did a CAT scan angiogram, and what that showed, the CAT scan showed a clot. As you can see here, this dark spot on the right side, on the right middle cerebral artery. We were able to give him TPA very quickly in the emergency room, and then we took him immediately to the OR for an endovascular intervention. And again, we went through the wrist. I was able to go through the wrist. And here you can see my catheter again going to the chest and going all the way up to the right side, the carotid. And this is when, taking pictures of the brain, this teenager had this blood clot sitting in the middle cerebral artery on the right side and causing the paralysis on the left side of the body. So I brought my aspiration catheter, which, the technique we just described, all the way up, engaged the catheter. And this is the result. You see how the clot is no longer there. Plus, this blood vessel that was not present before now is present. So, and this is the clot that I was able to retrieve. It's actually 0.5 centimeter clot, massive clot in this patient. So his deficits, fortunately resolved right away on the operating table, and the whole procedure took only 19 minutes. This is what you want to, what we try to aim to do it really very, in a timely fashion. And he was discharged home without any deficits, fortunately. No patient is too old as well. So this is a woman in her late 90s who was found down the next morning by her daughter. And she brought her to our emergency room. She was aphasic. Aphasic means you could not produce speech or comprehend speech. And she had paralysis on the right side of the body. Her CTA showed a clot in the left middle cerebral artery, as you can see here. Plus, like Dr. Khanna discussed, that patient had carotid disease, meaning probably the carotid disease here, as you can see, the narrowing in the carotid was the source of the clot and the stroke in that patient. So here you see how, this patient, I was able to perform the procedure through the groin. So here I'm coming from the groin, and you can see my catheter, my large bore catheter going all the way up. I'll play it again. So here, this is the chest. This is the carotid on the left side, and the catheter accessing the left common carotid. And first, what I encountered, like I expected, a severe carotid disease. You can see how narrow that segment of the carotid is there. So what I had to do first is bring my balloon, which you see here, this wire that is crossing the plaque, and inflate a balloon, and that's called balloon angioplasty. And this allowed me to restore the diameter, restore the lumen of the carotid in the neck, and allowed me to bring my catheter, my devices, all the way up to the brain. So next, I was able to bring my aspiration catheter in addition to a stent retriever, and was able to restore the blood flow. You can see how nicely reperfused the brain is, and the clot is completely gone. And this is the clot that we're able to retrieve. So that patient also improved immediately on the OR table. She was normal the next morning, and she actually went home. And interestingly, she had, she ended up being COVID positive, which is, it was her first presentation. So her first symptom of COVID was actually a stroke. And we have seen that an association between COVID and stroke. And especially in younger patients presenting with strokes in general, we suspect COVID, especially, in the current pandemic. Very good. So now, can late presenting patients benefit as well? The answer is yes, of course. Well, in general, we like to do it within 6 hours, but even if you present between 6 and 24 hours, you will still get a lot of benefit with endovascular therapy. This is the DAWN trial, a very well executed trial that was published again in the New England Journal of Medicine in 2018. And that trial compared endovascular therapy to just medical management for patients who presented between 6 and 24 hours. And again, the trial showed almost a 5-fold increase in the risk of a positive, favorable outcome with endovascular therapy. So patients presenting late, yes, do benefit from endovascular therapy. Now, how can we continue to improve stroke care? One thing, we're working on here in the University of Florida, and it's become more and more popular across the country, is a mobile stroke unit. The idea behind the mobile stroke unit is really to take the stroke unit to the patient, to the patient's patient's house, or where the stroke occurs. And the beauty of a mobile stroke unit is you can get the patient in the stroke in the unit, perform a CAT scan right on the spot. The CAT scan can show if this is an ischemic stroke, and if that's the case, TPA can be given within minutes of arrival to the scene, and then there's capacity to performing even more advanced imaging in a stroke unit and a mobile stroke unit. And if the patient is found to have a large vessel occlusion, then they can be directed to a center that can perform endovascular therapy for reperfusion. And then finally, robotic assisted thrombectomy. The idea here is that a surgeon can operate remotely on a patient using a robot. You can see in the picture the robot. It usually requires, a hospital to have a robot, and requires a technologist to be present to basically help set up the robot, while a surgeon can remotely operate on the patient and retrieve the clot remotely. This is not being performed yet. The idea is there. The technology is not fully there yet, but there's definitely, I personally was trained. I am certified to use the robot because we're, that's going to be the future, and this is how we're going to be able to provide stroke care for a large number of patients without having to have comprehensive stroke centers in every town. Very good. So finally, every patient who is suffering a stroke should be evaluated for TPA. And then, if they do have a large vessel occlusion, for endovascular therapy. And again, the message here is time is brain. We treat every case like an emergency, and every minute will save 2 million neurons again. Okay, thank you for your attention.
Wow, thank you. Those were some great presentations. I really appreciate both of you guys taking your time. We have several good questions that have come in, so I'm going to go ahead and just get to them. I appreciate it. Someone indicated that their older brother had a massive stroke and wanted to know what's the best advice you could give for like their younger siblings. Like if you could just give them 1 or 2 tips, knowing that their older brother had a massive stroke.
I think just like everything else, a full evaluation by a doctor with some stroke expertise would be helpful, and making sure that all the risk factors, which I discussed maybe too much in depth, are well controlled. So making sure the blood pressure and cholesterol and sugars are well controlled. I think that's probably the best recommendation.
Okay, thank you. There's a question about low dose aspirin. A person says that I had AFib and an ablation. My heart rhythm's been normal. My CHAD score is 1. Should I stay on 81 milligrams? Or, and maybe you're not willing to answer that because it's a little specific, but also what's the current knowledge about the benefits of the 81 milligrams of aspirin?
So 81 milligrams of aspirin is just as effective as any higher dose. So that's a good dose. And atrial fibrillation, if ablation was successful, meaning there's no longer evidence of atrial fibrillation, so the heart rhythm is good, or what we call in sinus rhythm, then you do not need any blood thinners, and aspirin 81 milligrams should be sufficient.
Okay. Someone says, my cholesterol levels are fine. How important then is it for me to eat a heart healthy diet?
So heart healthy diet is important for everyone. It doesn't just work for cholesterol, but it also helps with other things like memory and keeping your body fit. So a heart healthy diet is not just for stroke, but for the entire cardiovascular system, good for your heart. And also there's other arteries that we have that go to the legs and the arms. So that diet is very beneficial, and I would add some exercise to that as well.
Okay, thank you. A person asks, I'm on Agravox. What precautions should I be taking?
So that's that medication, Agranox is I think what I'm getting, which is a kind of a mild blood thinner. So there's really no particular precautions. It's a very mild blood thinner. It's unlikely to lead to any kind of bleeding situations, but just as anything, if you get a severe cut or have any kind of severe head injury, then that's always, you should, if you get a headache or you get knocked unconscious, then you should really get checked out. But it's a very, very low risk medication.
Okay, good to know. A question we have is, what do they offer at a comprehensive stroke center that they don't offer at a community hospital?
Well, Dr. Chalouhi is for one, so we offer Dr. Chalouhi. So comprehensive centers, we have a lot of resources the community doesn't have. Number one, we have these well-formed stroke teams, which include stroke neurologists, special ICU type neurologists. We have our neurosurgeons like Dr. Chalouhi. He's not alone. He also has other partners. So there's 3 of them now and soon to be 4. We have, for example, 5 stroke doctors that are trained in stroke and 7 ICU neurologists that are only trained in ICU. Plus, we have many, many trainees. We have residents and fellows and nurse practitioners. So we have big teams, and we're able to take care of patients with big teams. We also have specialized ICU and special operating rooms. So Dr. Chalouhi and his colleagues could perform all the magic and getting those clots out as fast as possible.
Yeah, a lot of that really fun and new technology that we have at the Heart and Vascular and Neuromedicine Hospital is amazing. When we were touring that, when it was opening up, to see all the great tools that are just right there in one spot. That's pretty amazing. So,
but the one thing we don't have is the mobile stroke unit. So I'm glad that Dr. Chalouhi brought that up, because that's the one thing I think we need in the community. So we're hoping that we get some more support.
Maybe there's a person out there in the community who's watching today who would like to help facilitate that. So if they do, reach out to me. I'll help get that to happen, because that sounds like a really neat, not really neat, but a really amazing thing that you could do that out in the field. I mean, yeah, we're at the point in our town where we could use something like that now. So
I think Dr. Chalouhi was trying to say something.
Yeah.
No, I was just saying that the devices we're using are really getting better. Every day we get new devices that are, allow us to even get to more distal strokes and be successful in doing what we do here.
Yeah. Well, kind of related to the ambulance that we saw some information about. Someone asked a really interesting question. They said, I live out in the country. Should I wait for an ambulance, or should I have a friend or family try to drive me in to save time?
We really recommend that the ambulance takes you to the hospital. We've looked at it just even recently. We just published an article on comparing people that come by their own vehicle to those that come by the ambulance, and treatment is much quicker when you come in with an ambulance, because the ambulance sets a signal. So the entire stroke team arrives in the emergency room even before you arrive. So we're kind of waiting for you to get there, and then we can expedite care, much more efficiently. So I would definitely recommend an ambulance is definitely the best way to go. However, if you're in a location that an ambulance can get to, then I guess you have to do what you can. But often ambulances come pretty quickly, and we also have helicopters. So they can land in certain locations, and sometimes an ambulance takes somebody to an area where a helicopter can land and can pick you up and bring you to the hospital.
Yeah, good. That's an important thing to remember. I forget about that. Shands Care the ambulance can be driving and Shands Care can be flying, and they meet on the side of the road at a spot and get you there even faster. So another question is, are there any diuretics to be cautious of? I'm not sure if that was, I assume, related to stroke, but.
Diuretics, so those are like the kind of medications that are used for blood pressure. So those are actually good. They help with blood pressure. They're not really associated with a stroke risk. However, I'm wondering if the question refers to maybe people taking those and then passing out and getting too low of a blood pressure. So we actually find that low blood pressure is not often associated with passing out. In fact, lower blood pressure people, well-controlled blood pressure people, have less passing out episodes than people that have poorly controlled blood pressure. So I would say, as long as the primary doctor feels that it's safe and the labs are okay, it is not none of the diuretics are a risk factor for stroke.
Okay. So kind of related question, can low blood pressure cause a stroke? If so, what would the number to watch out? What would the low number be to watch out for?
So we recommend blood pressure of less than 120/80 as being target. Now that doesn't work for every single person. And some people may need a little bit of a higher number of, like, say 130/80, 130/90. And just remember that blood pressure is not going to be, it's not static in time. So it's not going to be perfect at that number every single day, every single hour. Blood pressure fluctuates. It fluctuates with what you eat. It fluctuates if you're nervous, if you have anxiety, those kind of things. So when we say control at 120/80, it's most of the time. It's never going to be all of the time. So low blood pressure can be associated with a stroke, but very, very rarely, and that's only in particular circumstances. If you have a blockage, like for example, in one of your neck carotid arteries, and you're getting very little flow past that blockage, and then all of a sudden your blood pressure suddenly drops, then yeah, that can probably be associated with strokes. But most people with normal blood pressure, even if your blood pressure drops down to a level of, say, 80, the top number, you usually should not have a stroke unless something else is going on.
Okay, here's a question. I kind of wondered this as myself. How is the wire guided? How does the guide wire not pierce the artery or go into the wrong artery?
It's a good question. That's why there's a long training for that. It definitely is a risk, right? Whenever, we intervene on fragile arteries in the brain, that the wires are, gonna perforate the blood vessel. And, if that happens, it's usually, a big hemorrhage in the brain. It's a little bit like TPA, right? There's a risk of hemorrhage, but everything is risk and benefit. And that's why we've, performed those trials. And usually we can direct the wire under X-ray guidance. We, exactly know where the wire is going, by, under X-ray and by feel as well.
Here's another surgical question for you. What percentage of strokes end up with surgery for like a blocked carotid artery?
Blocked carotid artery, in general, they tend to be less than 10 to 15%. In general, it's primarily, middle cerebral artery strokes that we see the most.
Okay. Is there any way you can reduce plaque buildup in your carotid artery without having a stroke? Like before you have a stroke, I guess?
I mean, maybe without surgery. Yeah, actually you can. And what we've seen, because we run several trials, is that when you control risk factors and you put people on high dose cholesterol medicine, and we repeat an ultrasound or some other study that looks at the carotid, sometimes those cholesterol plaques actually get better. And I've had people that we're even considering for possible surgery in the future, and then they're really well controlled with their risk factors, and their carotid gets to the point that they don't need surgery anymore. So it's not the norm, but definitely those medications like the cholesterol medicine, the statins, really help.
Okay. Here's a question. I have a 4.2 centimeter aneurysm in my ascending aorta. Does this put me at an increased risk of a stroke?
Ischemic stroke, in general, I mean, again, Anna can weigh in too, but the aneurysms in the abdomen in general are the result of atherosclerosis, meaning plaques. And if you do have one in your abdomen, you might have the same disease in your carotids and your brain, which yes, could put you at risk. Although I don't think there's a direct association between the two. But I'll let Anna weigh in as well.
I mean, I think I fully agree. I think it's a low risk, and at that number, it's kind of something that has to be monitored. Usually surgeons monitor that 4.2. They don't operate on those. But just as Dr. Chalouhi points out, is that risk factor modification doesn't just work for stroke. It works for all arteries that are inside our bodies, including the ones that go to your heart as well. So we gotta, especially blood pressure with an aneurysm, is very important to control.
Okay. Here's a question like post-stroke. Is physical therapy for loss of mobility promising after a stroke?
Yeah, it's not just promising, it's very highly recommended. People get better with physical therapy. I mean, miracles happen with physical, like good stroke type physical therapy is really amazing. And for the audience that is living in the Villages Hospital has an incredible inpatient rehabilitation center at the Villages Hospital itself. I think it's on the 5th floor. Other very aggressive rehabilitation facilities. We have one here, it's called UF Health, Brooks and Jacksonville, and I forget the name, Encompass in Ocala is very good. Those are very aggressive therapy places.
Okay. Does a person with chronic headaches and migraines run a higher risk for stroke, especially female?
So migraine does carry a very slightly, if that, increased risk of stroke, but it's a very, very small risk. Nothing that we really speak of. I think having other risk factors probably overweighs the risk of migraine significantly. So not so much.
All right. Let's see. We have some questions about, so you're put in the ambulance and you're having a stroke, or your loved one is there with you. What kind of role do you play in what kind of role can the patient or the family member play in what stroke center, what hospital they get taken to?
So, I think family and patients definitely can choose where they want to go, and they could direct the ambulance to go there. Also, we have partnerships with many local hospitals, and as most of you are aware, the Villages and Leesburg are part of UF Health now. So we provide all of their stroke expertise to the Villages and Leesburg, so they directly can put us on camera. We have what is called telestroke, telemedicine, where through our camera we can communicate with the emergency departments there. And then other facilities are always free to call us to transfer anytime, but patients can come here direct as well. And sometimes if you're kind of too far, it may be beneficial to go to a local facility and be transferred if needed.
Okay. Someone asked a question about a C19 or long C19 patient. I'm not sure what that is. Is there any way to prevent them from having a stroke, or any recommendations you could give for that?
Can you read that again, a C19?
It says, is there any way for us, maybe it's for a COVID-19. So is there any way for a COVID-19 or maybe a long haul COVID-19 patient to prevent the possibility of a stroke? Or do they have can they have more than one?
So in the beginning, when we knew nothing about COVID, when all the studies came out from China, it was believed that COVID-19 was associated with about a 5% risk of stroke. Now that we have a lot more patients that we studied across the world, what we're finding is the risk of stroke is about 1%. So although it's there, but it's rare, and it is definitely more associated with people that have more severe COVID and have other COVID-associated conditions such as clotting or bleeding type of disorders. So it's not the common presentation, but we do see it.
Okay. Here's another question that said, thank you, that was amazing, by the way. And it says, my parents both had massive strokes. These types of surgical technologies might have or would have saved both of them. This gives me a lot of hope for those around me who have these cerebrovascular incidents. My question for the doctor is, isn't a clot retrieval procedure a solution for a clogged artery in or around the heart? If so, why would we ever have to have a bypass surgery again?
That's true, actually. We don't perform bypass anymore in the brain, and especially in the setting of acute stroke. Like I said, the whole procedure takes about 15 to 20 minutes because, like we said, time is brain, you have to do it quick. And, a bypass would take 7 to 10 hours. So
I think what their question is, and maybe you said it correctly, was like, could you use the same technology in the heart instead of doing a heart bypass? Why could you not go get the clot out of the heart like that?
It's present in the heart. It's been present for
a
long time. Stents in the heart, balloon. Basically, they applied that in the heart first, then we kind of copied them in the brain. But it's, there's certain indications. I'm not the best person, I'm not a cardiologist, but in certain patients that have multiple coronary arteries that are clogged, it might be better to do bypass than placing 5 stents, for example.
Okay. Someone asked a question that said, your 120/80 blood pressure recommendation kind of is different than what my primary care says. They say 140/80 is okay. Which one should I be listening to?
Well, I can't say, listen to me, but so I'm just giving you guidelines from the American Stroke Association, and the guidelines are 120/80. I somehow, especially with the carotid artery problems, I kind of stick to maybe the 130/80. And those are just national and international guidelines. So I can't say I'm right. I'm just giving you the information that's out there from their Stroke Association.
Okay, I got a couple of questions relating specifically to Ocala and the villages. One wanted to know, is there a mobile stroke unit in the villages? Do you know?
So we don't have a mobile stroke unit anywhere. Actually, we don't have one in the entire state of Florida. So one does not exist. So it would be really great if UF Health had the very first mobile unit in the entire state. And we're looking for people that are willing to financially support this endeavor. And if you have any ideas, please let us know.
Okay. And then someone also asked, are there other comprehensive stroke centers in the North Central Florida area?
Yes. So there are different types of comprehensive stroke centers. So the highest level, meaning sort of The most rigorous accreditation process is what is called the Joint Commission. And in the North Central Florida, there's only one Joint Commission comprehensive center, which is UF Health. However, there are other state designations. One of them is called ACA. And there are ACA comprehensive centers, which is North Florida, and Ocala Regional Medical Center are both ACA. They're not Joint Commission. So there are others, but the standards are a little bit different.
Okay. Let's see. Someone said that they had a pacemaker and their pulse was only 33, felt dizzy and breathless while taking a walk. Blood pressure and cholesterol are normal. Should I explore my stroke risk?
So the reason that somebody gets a pacemaker placed is because their heart rate is too low, usually because the pacemaker is set for a particular heart rate. So when your real heart rate drops, that pacemaker will set a pace for it and it will set the heart rate at whatever level is designed. So a pacemaker is not a particular risk for stroke. So if you're still feeling dizzy and you feel that the heart rate is really low, then you should talk to your cardiologist. That would be really important.
Okay. We have just a couple more questions if you have a minute. I've been diagnosed with a tiny cavernous malformation, 0.06, which was an incidental finding. But I'm wondering about the wisdom of taking aspirin or even fish oil due to the blood thinning properties. Is that something that we can answer?
It's not a contraindication having cavernous malformation in the brain to be on baby aspirin, but again, we can't make recommendations. It depends on every case, and but in general, taking a baby aspirin prevents stroke and does not increase the risk of bleeding from a cavernous malformation or an aneurysm. In fact, it decreases the risk of bleeding from an aneurysm.
Okay. And then another question is, they have a family member who's 92 with high blood pressure, taking propranolol and 2 acetaminophen daily, has had very, very bad edema on the ankles. Are they at risk of a stroke? Do any of those things make them at higher risk?
No, not really. I mean, age is a factor, obviously, that makes everybody higher risk as people get older. But the propranolol is a good medication, and ankle edema or swelling is not a risk factor.
Okay. This person once just said that they had venous reflux disease in their extremities and uses compression stockings and is also on Vytorin for high cholesterol. Are there any recommendations besides diet and exercise that could help prevent a stroke?
I think it sounds like the Vytorin is a great medicine. So that's a combination of a statin, cholesterol medicine, and a blood pressure medicine. So I think that's a good way to reduce, the risk. And also, obviously, the exercise and healthy diet is very beneficial as well.
Okay. And then our last question here. I was on 81 milligrams of aspirin because of paroxysmal AFib. I had an ischemic stroke in December and was put on Eliquis 5 milligrams. Now it's down to 2.5 milligrams. Is aspirin not sufficient now? I was given TPA, but nothing else.
So aspirin is not sufficient to treat atrial fibrillation related stroke. Really, Eliquis is the best medication. I'm presuming it's 2.5 because of other things that are going on, maybe some kidney issues or other things. But Eliquis definitely is the best drug for atrial fibrillation for stroke prevention. However, if there are other things that you can't be on Eliquis, then that has to be addressed with the primary care. And it's very difficult for us to make those definitive recommendations without seeing the whole medical history and the person.